look into the endocrine function. And so we're going to continue our study of the symptom survey, and we're going to be looking at nutritional strategies to help balance the endocrine system. And the hormones are obviously probably the most delicate or challenging of the systems that I work with, and there's a lot of overlapping and sometimes confusing symptoms. We're going to talk about that, but the thing to remember is that we want to stick to our strategy, which was treating those high priority groups first of digestion, liver, biliary, and blood sugar management. Because when we address those, we see an improvement downstream, typically in the endocrine system. So I'm not usually going to be addressing endocrine system right off the bat with patients, other than maybe some things to do some support for adrenals, and that they will be affecting our blood sugar management. So again, our ultimate goal is to influence our patients in eating a better diet, a lower carbohydrate diet, getting them exercising, and getting them addressing strategies to reduce and manage their stress. So I chose today's quote as we're sort of getting close to the end of our Building a Comprehensive Nutritional Practice series, in that it sort of mirrors our journey as healthcare practitioners, and that we're never really sure where our next step is going to be, but we're on this path, and we really enjoy following each patient through their journey towards better health. So to the endocrine system. So the thing that kind of my caveat for today is there's a lot of information with regards to hormones and the complexity of hormones. And there's just no way that we're going to be able to cover everything that has to do with hormones and hormone balance in an hour. And so again, I want to reiterate the idea that our strategy at the simplest terms, and what I use on a daily basis, is I want to remove those burdens to healing of my target tissues, whether that be the pituitary or the adrenal or the thyroid. And I'm going to do that by supplying the protomorphogen. And I want to provide a nutrient-rich diet in which to nourish those target tissues. And so one great way to do that, if we go back to our very first presentation, is the General Health Pack. And the General Health Pack, giving us our catalin and our trace minerals and our tuna omega, gives us a great opportunity to nourish those target tissues. So while I may not directly mention that as we talk about strategies for different endocrine organs, remember that we need to be supplying some sort of nourishment in addition to our protomorphogen to be fortifying those target tissues. So we're moving into group 7, and group 7 has 6 sections, and you'll see on the symptom survey here, we're dealing with this rather large group here. And where we're going to start is we're going to go in order. We're going to look at thyroid function first. So of course the thyroid is the endocrine organ in the neck. And I think what we'll start with thyroid is just kind of giving an overview of what the thyroid makes and who influences it. So of course the thyroid is responsible for making thyroxine, that's our T4, and T3, the triiodothyronine, that's the more active form of thyroid hormone that requires a conversion, and that conversion may be limited, and if you're doing lab tests, you may see a situation where T3 levels are maybe a little lower than they should be, T4 is a little higher than it should be, and that's a special situation where we have a conversion problem. Of course, under periods of high stress, reverse T3, which is an isomer of T3, can be a receptor blocker, and that can give us symptoms of low thyroid function, even in the presence of adequate T3. So if I've got glue in my keyhole, I cannot insert my key and do the job that lock unlocks. So reverse T3 tends to be elevated under high stress situations or adrenal situations. So again, right away we're looking at that interconnectivity and how the adrenals will affect the thyroid, and the pituitary is the middleman that can affect all of that. The other hormone that we see made from the thyroid is calcitonin, and calcitonin has a pretty important role with regards to putting calcium into bone tissue. And of course, I'm sure most of you are aware that the pituitary secretes thyroid stimulating hormone, which allows or stimulates the thyroid to create both T4 and T3. And of course, the pituitary, being the middleman, is getting its stimulation from the hypothalamus by means of thyrotrophin releasing hormone that tells the pituitary to create TSH. So we've got that little feedback loop going there. And kind of in that slightly blue highlighted, cortisol levels are important with regards to thyroid because they will inhibit high cortisol levels will inhibit thyroid function. So we can, like we said, we may get an increase in reverse T3 and start blocking some keyholes, and we may start seeing a reduction in the efficacy of thyroid hormone when cortisol levels are imbalanced, particularly when they're high. So if we look at a cross-section of the thyroid, we see kind of these large follicles, these big areas, and this is where we have our iodine storehouse. So we bind iodine with protein, and we call that thyroglobulin, and that's the raw materials, the bricks that we build the house out of. So our follicular epithelial cells take that storehouse of protein-bound iodine and create T4 and T3. And then if you look closely, these little cells in between the follicles, those are those those are the parafollicular cells, and those are the guys that are creating calcitonin. So without spending a whole lot of time, I thought it would be great to kind of give a chart on blood labs and how to interpret or think about thyroid function. So at its kind of its simplest terms, if we have just a simple primary hypothyroidism where the actual thyroid itself is under functioning, we would expect to see T4 and T3 being kind of low, and of course we'd expect to see TSH as high. And opposite, in a case of hyperthyroidism, we would expect to see elevated levels of thyroid hormone and a low TSH. Now, there are a couple of situations where we have an actual autoimmune attack against the thyroid. One will create a hyperthyroid situation, that's Graves' disease. So again, we're going to have very similar lab readings as we would with just run-of-the-mill hyperthyroidism. Although the thing that'll be different is we'll see some antibodies in the blood. Probably the most common thing that we see from an autoimmune standpoint is Hashimoto's thyroiditis. And you'll notice on here that every single one is variable. That's because in the early stages of Hashimoto's, the thing that we can see consistently is really high antibody levels. But in the early stages, you may be exhibiting some hyperthyroid symptoms, and then as the disease progresses, it will move more towards a hypothyroidism. So the tests that I tend to pay the most attention to from a lab standpoint is TSH, free T4, free T3, and thyroid antibody. So let's jump right into our symptom survey. And kind of what I'm doing today with today's presentation is I'm looking at what I would call the typical WebMD approach to how they would suggest a hyperthyroid patient would present. And so you'll see, over here on the right, they have palpitations and they're intolerant to heat. They're a little bit more nervous, have a little bit more insomnia, a little bit more breathless. So this is a person whose metabolism is elevated. And so these ones that are highlighted in the yellow, these are ones that are overlapping with things in the actual symptom survey. So you can see most of us are in agreement with regards to what we would expect to see in a hyperthyroid situation. Now, at its most glaring or most obvious, particularly when there's an autoimmune reaction occurring. Excuse me, I gotta clear my throat. We get a situation that's really obvious. This is the Graves' disease. This is the autoimmune hyperthyroidism. And the key symptoms that we see when the thyroid is really overtly hyperfunctioning is this myxedema or tissue thickening in the anterior shin or the anterior tibia. They call this pretibial myxedema. Sometimes they'll also call that a dermopathy or skin disorder that's associated with Graves' disease or hyperthyroidism. Of course, the other thing that we learn from our textbooks and we remember from school is the obvious bulgy eyes, the exophthalmia or the irritation. And while maybe not every day this walks into our office, it's certainly something that I have seen, and I think most people, if they practice long enough, are going to see the effects of a hyperthyroid situation. Uh, so even as simple as somebody that complains of really irritated eyes, that may be we're moving into allergy season, so that's something to certainly pay attention to. But if it's persistent or consistent and it doesn't get better with simple allergy strategies, start considering that maybe there's a little bit of a hyperthyroid situation being created. Now, if we can address and correct that autoimmune response before it becomes fully blown, we have done what we really are meant to do as doctors, which is preventing disease before it starts. So I kind of included this picture just to kind of iterate that the thyroid can have a goiter in either condition. So obviously this person is wasting. This is a pretty advanced case of Graves' disease, but notice that the thyroid is obviously enlarged in this case as well. So goiter in and of itself doesn't mean anything to me other than investigate thyroid function. So what's my strategy? My strategy, and kind of we're moving from left on the slide to the right. And so I kind of go from smaller image to larger image to show you kind of the general to the specific. For virtually all endocrine disruptions, our basic approach is to supply a mineral, in this case organically bound minerals, or trace minerals can be useful, and either simplex F or simplex M, because that's going to provide the protomorphogen for the majority of the endocrine tissues, that being the pituitary, the thyroid, the adrenals, and either the ovaries or the testicles, depending on simplex F or simplex M. Now it's important to remember from last time we were talking about sympathetic parasympathetic balance and how occasionally if there's a situation where there is a parasympathetic dominance, you may want to pay attention to that because you may want to use paraplex instead of simplex F or simplex M as your basic general strategy for any of the endocrine disorders, including hyperthyroid. So with hyperthyroid and hypothyroid, as we move a little bit more specifically, we start going into the more direct approach, which is giving directly the thyroid protomorphogen or thyroid PMG. So the other thing that I do and we recommend is Antronex will help clear that excess T4, T3, help clear a little of that excess histamine that's produced in a hyperthyroid state. Now, the real trick to treating a hyperthyroid situation or a Graves' disease is obviously that this is an important medical condition and may need to be addressed by an endocrinologist. But many of my patients will go that route and then come to me and say, now what can we do before I start doing their recommendations, which may be a radioactive iodine or this or that. So if I'm lucky enough to be the person that catches this diagnosis in its early stages, this is where I want to do things like bugleweed and motherwort. I don't use liquid herbs a lot in my practice, but this is a great product for mitigating thyroid function. If you marry this to thytrophin, where we remove the burden of the autoimmune attack on the thyroid, we can sometimes reverse Graves' disease and hyperthyroidism before it becomes an issue that needs to be treated medically. So bugleweed and motherwort are very good at doing things like calming the increased heart rate and the restless feeling and the thin skin, the tremors, and the things that we see associated with that side of the symptoms survey. So, bugleweed, motherwort, about a teaspoon a day. If it's more overt or more severe, might do 2 teaspoons a day. And I wouldn't be against taking a bottle of each and blending them, just pouring them together in a new bottle and dispensing it that way. A third herb that you could add to that is lemon balm. Lemon balm is not something that's available through MediHerb, but lemon balm also has a really good track record with regards to treating hyperthyroidism. Now, as we move into hypothyroid, again, we kind of look at the typical clinical correlations versus our symptom survey, and we have quite a few overlap: the weight gain, intolerance to cold, drier, thinning hair, and one of the things that we when I'm looking through the symptom survey, I'm thinking, what else could this be? So, for instance, with drier, scaly skin, I'm thinking, yeah, that could be thyroid, but perhaps this person just needs some fish oil, some omega-3s. Constipation also is an issue that we addressed earlier with not only digestive function, but also gallbladder, biliary function. So when we go hypothyroid, we start thinking of lower metabolic function. So we see some reduced initiative, some slower pulse, things of that nature. Again, I don't get too excited about slower pulse. A lower pulse is consistent with longer life. So that's not necessarily one of the questions in the symptom survey that I get too excited about. Similarly, question 134 is a question I don't see answered very often because I don't think people know how to answer it, and that's frequency of urination. So does that mean I pee a lot, or does it mean I pee not very frequently? So I think we get a lot of wrong answers on that. So I would suggest if you see that and there's some other urinary symptoms, I'd ask questions more specifically. Does that mean you're waking up more than once a night to urinate? In which case that may be a blood sugar issue, diabetes, or it could be a posterior pituitary issue, which we're going to talk about later, diabetes insipidus. So know that some of these symptoms in the symptom survey are really designed for you to kind of pay a little bit more attention to other areas. So in the overt hypothyroidism, particularly at birth, we see these situations that we call cretinism, where the tongue is oversized, doesn't fit into the mouth, and some obvious developmental abnormalities. Of course, these children have low thyroid function, so they're not thriving, they're not growing. And again, the importance of thyroid with regards to driving full maturity or sexual maturity. So it's not that these children are dwarves or that this gal has any sort of genetic trait beyond the lack of thyroid function. So I believe this was over the course of 6 months. By introducing thyroid hormone, you see her come into sexual maturity fairly quickly, and she even grows a few inches and quite a bit of hair. So I put these, excessive or obvious disease state pictures in kind of to remind you the simplest things that you may see. For instance, when I have, kind of that preteen teenage girl coming into my office, and she seems small of stature. She seems underdeveloped for her size. Her hair is thinner or brittle, or by the same token, even a young male who isn't lowering the voice, who isn't going through those secondary sexual characteristic changes. Again, I want to start thinking, is this thyroid? Of course, it could be pituitary, which we're going to talk about next, because pituitary is responsible for telling the thyroid what to do. So we're going to see a lot of overlap. So the obvious things that I see every day are people that come in and they have an overly developed face. And it's not just because they're obese, it's not just because they're overweight, but because they're hormonally imbalanced. So if we lay down that extra connective tissue instead of in the anterior shin, we do it in the face, we get what we call myxedema and kind of that moon-shaped face. So again, this is kind of a pre and post hormone therapy, thyroid therapy. In this man, you can see the profound changes it makes in defining the shape of his face. So other things that, like I said earlier, goiter can happen either way. So don't put any relative weight on goiter being a hypothyroid sign or a hyperthyroid sign, but just a sign of thyroid in general. And hair loss being a really big one, or thinness of the hair, or hair falling out. So a good question that I ask my patients is, are you noticing more hair in the sink or in the shower when you're cleaning out the shower drain? And with my female patients, of course, when I see that lack of hair growth on the outer third, the outer half of the eyebrow, I need to ask if they shape or pluck their eyebrows. And if they do, then I don't have a ball game. I don't have anything to compare it with. But if it's a man, or if they tell me that they don't, then that loss of hair, particularly past that lateral border of the eye, that the eyebrow should go all the way to here and then some. But if it's abbreviated before the end of that eye, that's certainly something to consider as a low thyroid function. Libido is going to be affected, so we can see erectile dysfunction, low sex drive, things of that nature. And of course, the obvious one is weight gain or obesity. And I like this picture because it's it's obvious this cat has a hormone problem, thyroid problem. So we haven't had a lot of opportunity to address that. Standard process obviously does have a veterinary line, and while it's not a big part of my practice, it certainly is a big part of a lot of people's lives, and they have cats and dogs and horses with diseases and problems, and we can certainly address those. If not with an actual veterinary formula, we can do that with the regular standard process line. So I wouldn't be afraid of giving this cat some thyroid support, either through the canine thyroid, or give it thytrophin and some nutrients to help nourish that thyroid. And for more information, not really my specialty, but there's a mentor with Standard Process West. Her name is Tracy Hoffman. She's a vet tech. So any questions you have from a veterinary standpoint, you can certainly shoot those off to her at SP West, and she can get those addressed. And a quick one that I like to pay attention to is that Hashimoto's thyroiditis or Graves' disease, any autoimmune attack on the thyroid, and I kind of included the little lab screen here. When we see those thyroid antibodies going up, that has a really strong correlation with gluten sensitivity. So I just included a handful of some references that back up the connection or the relationship between gluten sensitivity, celiac disease, and thyroid autoimmunity. So when we move to hypothyroid treatment, we've got the same general strategy with the knowledge that maybe they're a little bit more parasympathetic dominant, so we may want to entertain the thought of paraplex over simplex F or M. And organically bound minerals, we may entertain the idea of a little bit more trace minerals B12 instead. Of course, the most important mineral for thyroid function is going to be iodine. And iodine we can address with a protein-bound iodine like iodomir or prolamine iodine. Thytrophin remains the same, and in the hypothyroid situations, I introduce thyroid complex. And earlier we talked a little bit about that conversion of T4 to T3. If you're doing labs and you see an elevated T4 that's not converting to T3 because T3 levels are low or lower, that's where we want to investigate things like selenium to drive that conversion. So we call that a conversion disorder, not to be confused with the mental disease. So when there's a conversion disorder of T4 to T3, that's when we want to look towards something that's very selenium rich. And that's where I'll use Cataplex E to help drive that. Yeah, so I have a question. And so am I saying instead of using simplex FRM, give them paraplex? Yes. So I wouldn't do both at the same time. I would do either or, as they're very similar products. So for the person who's more sympathetic dominant, I'll be using the simplex FRM. And for the person who's more parasympathetic dominant, I would use the paraplex. And my decision making on that would be driven by going back to section or group 1 and group 2, that's the sympathetic dominance, and the parasympathetic dominant portions of the symptom survey. And if one of those is more notable, then I will go with that one instead. So if this looks like the person is more prone to sympathetic dominance, I'll give them simplex, and if they're more parasympathetic dominant, I'll give them paraplex. And another question was on the prolamine iodine. Does it contain iodine or iodide? And the question is yes, it contains both. And in fact, I believe it contains both in a very similar fashion to Lugol's iodine, if memory serves. So now we move into the third and fourth sections of symptom survey. This is pituitary, and like the thyroid, I want to kind of look at the hormones that are associated with the pituitary function. So right off the bat, we already kind of know about TSH. That's going to stimulate the thyroid. And the important ones that we haven't talked about yet are follicle stimulating hormone and luteinizing hormone. These both come from, of course, what we're talking about now is anterior pituitary. So follicle stimulating hormone in the female acts on the ovarian follicle to secrete estrogen. So that's going to be the early portion of the menstrual cycle. And in the male, it's going to stimulate spermatogenesis or sperm creation. Now, luteinizing hormone, the other pituitary hormone, is going to, in the female, a surge of it in that mid-cycle is going to stimulate ovulation. And then that remaining luteinizing hormone is going to stimulate that now empty follicle to become the corpus luteum, which is going to secrete progesterone, which is going to be progestational, or in some instances, be that which fosters pregnancy or gestation. So right away, just by looking at our hormones, I know that if I have a hyperpituitary situation, I'm going to have problems with or imbalances in estrogen and progesterone, so probably some female hormonal issues. In men, I'm going to see probably some situations that deal with increased testosterone, so keep that in mind. And by the same token, when we have lower function, we're going to see the opposite. Of course, the pituitary also secretes prolactin, which helps promote the synthesis of breast milk. It creates growth hormone, which one of the things it does is stimulates the liver to secrete insulin-like growth factor, which is here, and that stimulates growth in the long bones. And finally, the anterior pituitary secretes adrenal cortical hormone. It's going to stimulate the production of cortisone from the adrenal glands. It's also going to stimulate the production of aldosterone from the adrenal cortex. And aldosterone and the mineral and glucocorticoids, really important. This is where we start to get the interplay between obviously the pituitary and the adrenal glands. So again, can be very difficult to differentiate between, is this a an adrenal problem or is this a pituitary problem? Because it's the pituitary, it's telling the adrenal glands what to do. So cortisone, of course, our stress response hormone, and aldosterone is our guy that basically helps us retain sodium. So when aldosterone levels are high, just remember Big Al has high blood pressure. So if we have lots of aldosterone, that's going to tell the kidneys to hold on to sodium. If we hold on to sodium, water will follow. And if water follows, we're going to have an increase in fluid in our tissues, and particularly in our bloodstream. So we're going to see an increase in blood pressure. In order to hold on to that sodium molecule, we have to make a trade. We have to get rid of another positively charged molecule, and that positively charged molecule is potassium. So this is one of the reasons why I recommend organic minerals, particularly in a situation where I feel like aldosterone may be a little bit high, is because I need to make sure that that patient isn't going potassium deficient. Now, the pituitary obviously gets its orders from higher up. That's the hypothalamus. TRH, thyrotrophin-releasing hormone, of course, we talked about, stimulates TSH. Gonadotropin-releasing hormone, that stimulates FSH and LH, so that's female hormonal cycle and testosterone in men. Growth hormone-releasing hormone, which stimulates growth hormone, and corticotrophin-releasing hormone is what stimulates ACTH. So posterior pituitary is something we don't talk about as often, but I like to look at it because I think it helps give us a clearer clinical picture sometimes when we're dealing with patients. Of course, the most common thing that we think of is if we lose posterior pituitary function, we lose vasopressin, and that creates a mutation in its receptors, and then we start to pee like crazy. So that's diabetes insipidus. If the patient is complaining of extraordinary frequent urination and extraordinary output, and they're crazy thirsty, we need to investigate that there's not a pituitary tumor or something else that's creating that unusual diabetes that we don't see as much, the diabetes insipidus. The other two, of course, vasopressin we sort of just talked about. That's our antidiuretic hormone. So that stimulates the kidneys to retain fluid. We lose that fluid retention system when that fails, and so then we just start peeing like crazy. That's diabetes insipidus. But vasopressin also plays a role in circadian rhythm. Interestingly, it may, at least in monkeys and voles, which are mammals, plays a role in promiscuity and hanging around for child rearing. So put that in your pocket and think about that sometimes when you're dealing with patients that may be having challenges in that neighborhood. And of course, oxytocin, which is important for starting the contractions of the uterus at the time of birth, helps to regulate the release of milk. It also enhances bonding in the brain between males and females, at least in rats, and that bonding between a mother and her newborn. So if I'm seeing a new mother who may be having some of the depression that's associated with childbirth, that's what I'm going to start thinking about. Maybe I want to be really direct and do some pituitary help above and beyond something simple like Simplex F. And interesting, oxytocin is important for the ability for people to trust one another. So the higher levels of oxytocin, the more a person trusts you or will trust another person. So if we the thing about the pituitary portion of the symptom survey is the symptoms are pretty vague. And if we compare them to kind of what we would suspect for pituitary abnormalities, we don't really see any overlap. So again, that's kind of why I look at things like bonding, things like sexual behavior, and obviously hormonal influences at the testicular or ovarian level or at the adrenal level to make a determination of how the pituitary is doing above and beyond the symptom survey, because there's just not that many questions with regards to it. So we can assume if there's a hyperpituitary situation, particularly in a male patient, they're going to have an increase in growth hormone, they're going to have an increase in testosterone, so they're probably going to see an increase in sex drive. Something I cannot explain is if we have an increase in pituitary function, we'll have an increase in aldosterone, which should increase blood pressure. So I don't pay a lot of attention to this one from a pituitary standpoint, but I may address it from an adrenal standpoint. One of the things that Royal Lee talked about was when in pituitary headaches, the patient would talk about a splitting headache. So that's a great symptom for me to look further into endocrine dysfunction to seeing if we can address that. So if we look at the overt imbalances that occur with pituitary function, so we're kind of going to the obvious here. If you've got too much growth hormone when you're a child, so before your growth plates have finished or fused or completed, we're going to see an increase in bone length. So I went out of order. So too much growth hormone, we're going to see minute bull, we're going to see gigantism. And if we do not have enough growth hormone during childhood, we're not going to secrete as much insulin like growth factor, and we're going to see less growth in those long bones. So we're going to see somebody whose growth is stunted. Now, in growth hormone or anterior pituitary dysfunction, when we see, we'll call it dwarfism, I would say we see what is a very proportional dwarfism. So his arms and legs are of normal proportion. So unlike other dwarfs that have very short legs or maybe very short arms or a very short torso, when we see particularly growth hormone pituitary functions that are underfunctioning, they tend to be very proportional. So just for interesting purposes, Manute Bol, 7'7", tallest NBA player ever. Muggsy Bogues, 5'3", shortest NBA player ever. Now, if the long bones have closed and we've reached skeletal maturity and growth hormone persists, we're going to see bony growth in other places like the mandible, a little bit in the forehead. So this is really consistent with what we call acromegaly, and some pretty famous people with acromegaly is it Richard Keel, who played Jaws, and Andre the Giant. And the other thing you'll notice is they're going to get a lot more bony growth in their hands and their feet. So they have remarkably large hands and feet. So if on occasion I see people and that just have these enormous catcher's mitt hands, and right away I'm thinking, okay, could this be a situation where a pituitary might be in question? So hyperpituitary treatments, we're going back to our basic strategy. Give them the protomorphogen, whether that be in overt, straight, more concentrated form or a higher dose, or that which is found in either simplex F or M or paraplex, as the case may be. Again, hyperpituitary would mean hyperaldosterone. Hyperaldosterone is going to mean getting rid of potassium to spare or save sodium so that we can maintain blood pressure. In which case I want to deliver something that's potassium rich, that's organically bound minerals. So for the hyperpituitary, I need to consider upstream, and that's when I start looking at things like hypothalamus or hypothalamus PNG. Now when we look at the decreased side of the pituitary, fairly simply, we're going to see less hormonal production, less testosterone, so we're going to see a decrease in sex drive, which is something that is noted clinically not only in the symptom survey, but elsewhere. And we're going to have some hormonal aberrations in females. So, sorry about that. We're going to see some menstrual disorders and lack of menstruation, sex drive reduced or lacking. So these are really, pretty common sense when we look at the at the overall or overarching idea is that if we have low pituitary, we're going to have low hormonal function. So we'll see shorter stature, decreased facial or body hair in men. So that's something to pay attention to. This is a this is kind of a good time to talk about the importance of hormones and kind of how they play a role in our society. And you know, it's obvious when we see somebody who's who's obviously hormonally enhanced. Um, so I'm going to take a quick break and play a video.
Lance Armstrong's physiology characteristics are nothing short of astounding. He's possibly the best endurance athlete in the world. Armstrong's heart can beat twice that of a normal person. He gets almost double the amount of oxygen out of every breath that a healthy 20-year-old would. His muscles can go longer and harder without major fatigue.
This is a guy who had cancer in his lungs, his brain, his testicles. He went through chemo and lost one of his balls, for Christ's sake. And he's getting double the oxygen out of every breath. The question shouldn't be, was he doping? The question should be, why aren't all of us doping? I get winded lighting a cigarette.
So I kind of included that not only because it's funny, but because it kind of gives us some food for thought. How much is too much when we're talking about providing optimum function for our patients. And I certainly want to be able to do that. I don't necessarily want to be giving somebody the juice to hit more home runs. But if it means looking and addressing a person's hormonal profile to improve their performance, I think that's a very worthwhile endeavor. So how might we do that? Again, if we've got that lower pituitary function, we've got to stimulate it upstream with the hypothalamus PMG, pituitrophin. But there's some other things that I will investigate as well. Obviously, trace minerals B12 to add that full mineral complex instead of just organic minerals. But I will look at things like neurotrophin, neuroplex, and E-manganese is something that we haven't really talked about yet. We have talked about cytosol extracts, and we've talked about whole desiccated glands. E-manganese is whole desiccated pituitary gland with a little manganese in it. So if I need to if I have a male patient whose beard isn't growing, or they're starting to lose a step, or they're starting to go a little low testosterone, I'm certainly going to be looking at those things to try and improve that function. And same goes with the female patient. If I'm seeing hormonal dysfunctions, lack of periods, after I've ruled out things like they may have really low body fat, then I'm thinking, how can I encourage the normal production and secretion of estrogen and progesterone? And the way that I influence that most frequently is with the addition of chaste tree. One or two, depending on the size and severity of the patient, at night or first thing in the morning will really help regulate that pituitary function and modulate that estrogen and progesterone balance. Ovex and Ovex-P are the cytosol extract for ovarian tissue, so I can really drive that production of the follicle and the corpus luteum more effectively when I support that tissue, and that's Ovex and Ovex-P. For those of you that may not know, Ovex is of a bovine source, and Ovex-P is a porcine source, so virtually the same product. Just a different ingredient to make the product. So back to that idea of the male that has lower testosterone. This is really common. I kind of included this little newspaper clip because like it says, virtually half of all men over age 45 are affected by low testosterone. Now, I think the vast majority of that is because they're obese. It's because they're carrying too much body fat. And we know that abdominal fat, particularly around here, will secrete what's called um, my brain just went blank. Anyway, the hormone that secretes will convert your testosterone over into estrogen. So if we see belly fat, and I know that this patient is overweight, they're carrying a lot of belly fat. I'm not going to jump into a product like Tribulus to help stimulate some testosterone production. I'm going to be more inclined to want to influence their blood sugar. I'm going to try and get them to improve their diet, start exercising, and doing those things to stimulate testosterone instead. But for the patient who is already relatively physically fit, but is starting to see a decline in their prowess, so to speak, that's when I'm going to add a product like Tribulus to help naturally stimulate the pituitary to get a little more growth hormone, to get a little bit more stimulation of those Leydig cells in the testicles to produce more testosterone. So now we're moving into the adrenal glands, which is a huge topic in and of itself, but let's just start chipping away at it. So the adrenal cortex, so we're going back to what they make. The adrenal cortex makes cortisol, which is a potent anti-inflammatory, depresses the immune response, which in some instances is a good thing. It's a bad thing when we take it as a long term. That's how rheumatologists treat autoimmune diseases, is they suppress the immune system by giving exogenous cortisone or prednisone to reduce the patient's inflammation and dumb down their immune response. Of course, we've already talked a little bit about aldosterone, which is the mineralocorticoid that's made in that little outer layer here, the zona glomerulosa. And the internal compartment of the adrenal gland, the medulla, right there, that's really a mass of sympathetic neurons. And the difference being is those sympathetic neurons, instead of being kind of part of the nervous system per se, their neurotransmitter gets dumped into the bloodstream. So this is the endocrine function of the adrenal glands that relates to the nervous system. And of course, the pituitary is what stimulates the adrenals and the production of aldosterone through ACTH. So right away we know if we've got hyperadrenal function, we're going to have more cortisol, we're going to have more aldosterone, and we may also have more adrenaline or epinephrine. And the opposite is true if it's lower. So we go hyperadrenal, what do we see? We see dizziness, we see headaches, we see hot flashes, increased blood pressure, hair growth on the face of females where it shouldn't be, 155, sugar in the urine, not diabetes. I've never seen anybody answer that. If you do, let me know. And masculine tendencies in females. So if we look at the clinical correlations, we're going to see the round face. We're going to see kind of that apple shape or that upper body obesity. And obviously, aldosterone levels are higher, so we're going to see high blood pressure. And because we're perhaps secreting more epinephrine, adrenaline, we're going to see an increase in blood sugar because that's what that does. So if I'm hiking in the woods and I step over a rattlesnake or I see a grizzly bear, even if I'm starving hungry, even if I haven't eaten in hours, that adrenaline response that's going to be kicked out from my adrenal glands is going to go into my bloodstream and it's going to get to my liver and it's going to liberate storage sugar. So that is why we may see some high blood sugar in the hyperadrenal situation. Of course, when the adrenals are overregulated or upregulated, we're going to see a lot of other hormonal symptoms. So we may see a reduced sex drive and irregular periods in females. So let's look at the obvious, the overt, the disease state. So when we have overfunctioning adrenals and too much corticosteroid levels in the blood, we're going to call that Cushing's disease. So Cushing's disease can be from a aberrant function of the adrenal glands. However, it could be caused by a patient who's taking too much steroid. Particularly our patients with autoimmune diseases who are being treated medically with things like cortisone, prednisone, things of that nature. So the telltale signs of adrenal excess or cortisone excess is these really colored stretch marks in the abdomen. Of course, the central deposition of body fat, really easy bruising, and that kind of thicker buffalo hump on the back of the neck and shoulder. And again, that's similar to hypothyroid face, that myxedema, kind of full looking in the face, and of course hair growth. So my strategy for adrenal glands is enormous, but how do we do it simply? Simplex F or M, covering all of our bases. So I know that if that adrenal problem is coming from a pituitary issue, or even if I don't, this is the greatest place to start because it covers your bases. It's going to get your pituitary, your thyroid, your adrenal, and your ovary function. And again, organically bound minerals is my mineral choice because of the potassium. If the adrenals are overfunctioning, that means the potential for too much aldosterone. Too much aldosterone means losing potassium. So I want to replenish that potassium, organically bound minerals. So more specifically, on virtually all adrenal cases, I'm going to be looking at Drenamin. Drenamin not only gives you the protomorphogen for the adrenal glands, but it also gives you the nutrients necessary to feed that target tissue. More specific cases are where I feel like I need a direct approach, where I may not want to use Simplex F or M, I would use Adrenotrophin. And from an herbal approach, I'm looking at things like adrenal complex, I'm looking at Romagna complex. These are both herbal adaptogens, or things that help modulate adrenal function. So an adaptogen is something that will turn the volume down when it's too high and turn the volume up when it's too low. So one caution that I would give you with particularly adrenal complex is adrenal complex contains an excellent adrenal herb called licorice. However, licorice can create some blood pressure problems. So if your hyperadrenal patient has hyperaldosteronism as well, and therefore they're retaining lots of sodium and lots of water, their blood pressure is high, adrenal complex and its licorice may exacerbate that. So keep that in mind, important. It will also affect some of the medications that they may take, including prednisone. So if this person is hyperadrenal because they're on medications to manage an autoimmune disease, adrenal complex may not be your best bet, but Romagna complex is. So Romagna helps mitigate the deleterious effects of too much cortisone, an excellent adrenal product for patients who are taking prednisone regularly. So that would include your rheumatoid arthritis patients, and it would include your asthmatics who take a daily inhaled steroid. So now we move into low adrenal function, which most of us are probably pretty familiar with, and you can see that the typical clinical correlations overlap with the symptom survey quite a bit: weakness, dizziness, fatigue, an increase in skin pigmentation, we'll talk about that, joint pain, gastrointestinal disturbances, reduced blood pressure, we've got low aldosterone. So let's look at the obvious low adrenal function. So in its disease state, we see Addison's. So in the Addison's patient, they're not making any cortisone. They have virtually no stress hormone production at the level of the adrenals. As a result, they may also not be making aldosterone because the adrenal cortex may be completely destroyed. If there's no aldosterone, that patient is going to be craving minerals. They will be the person that says, I just can't get enough salt. And if given the choice between sugar and salt, I'm going to eat salt. So I have a lot of patients who do not have Addison's disease, but they certainly crave salt. And when I see that, that tells me that their aldosterone production may be a little bit wanting. And so that's how we make the correlation of low adrenal function is a person that craves salt, or a person that craves stimulants because they need things to deal with or help them cope with stress or low blood pressure. So this is kind of an interesting physiological aside, and I'm going to back up a few slides to right here. So adrenal corticotrophic hormone. It has a kind of a very similar hormone called melanocyte stimulating hormone. And ACTH and MSH, melanocyte stimulating hormone, which you can guess stimulates melanocytes, which are the cells that give us a tan when we get out in the sun. They have the exact same precursor molecule. And when the adrenal cortex, which secretes all of our aldosterone and cortisone and DHES, when that becomes deficient, the pituitary upregulates the production of ACTH and somewhat mistakenly upregulates the upregulation of MSH, that melanocyte stimulating hormone. And what we will see is the deposition of colorful skin melanocytes in places it should not be, like inside the buccal mucosa. So these little spots, these little dark spots here, are direct manifestations of too much MSH. And that's highly consistent with Addison's disease. So the thing that you'll see here is the crease of his hand is bronzed. Yeah, so when you go out and you get sun, so I was just in Hawaii last week, got a really nice suntan, but I did not get it in the creases of my hands because that's where the sun never hits. So that's the thing that's going to separate a person who's got a suntan from a person who's perhaps overstimulating that pituitary to creating melanocyte stimulating hormone. So that's a great reminder. Look at the hands, look inside the mouth, and you'll also see the nail beds don't generally get a lot of sun through the fingernail. They'll start to darken up, so that's something to consider. Salt and skin discolorations is something that may be telling you more about the severity of that person's adrenal gland dysfunction. So with regards to adrenal function, there's more products than I can fit on one slide. But again, let's go back to brass tacks and keep it simple. We can do our basic simplex F, simplex M organically bound minerals, or if necessary, trace minerals, or both, to make sure that we're addressing that. Adrenamin is my go-to product because it's going to have the protomorphogen as well as the nourishing uh, uh, nutrient component. Adrenal complex may be very effective here. Just make sure that the patient doesn't have hypertension. And if their blood pressure is, kind of on that slightly vaguely high, 130 over 85, I wouldn't be afraid to put them on adrenal complex so long as I was monitoring or watching their blood pressure. For the person who is overtly high blood pressure, I'm going to avoid adrenal complex altogether, and I'm going to be looking at things like not only the Romania that we talked about previously, but rhodiola, ginseng, and eleuthero as excellent helpers for boosting or fortifying adrenal function. So kind of differentiating between these two, one of the ways I think about it is if the patient that I'm treating with lower adrenal function is under a very high stress occupation that requires a lot of mental acuity, a lot of on topedness of lots of different tasks, I tend to go with rhodiola ginseng. So if their primary stressor is mental, I give them rhodiola ginseng. If their primary stressor is physical, so now I've got a patient who's going low adrenal function and they're very athletic, they're working out quite a lot, that's when I do eleutherococcus, which is also known as Siberian ginseng. Both of these would be excellent products for either. That's just one of the ways I think about breaking it down. sorry, I don't have a very clear picture. This is Withania complex, and this is another great herbal approach to helping the person who is so wound up they can't wind down, they can't relax. So Withania complex has a little bit of ashwagandha, that's what Withania is, as well as a little bit of Shazandra, a great nerve tonic for bringing some energy back to a person who's starting to lose a little stamina. So a great one-two punch for any low adrenal function would be Drenamin, and any of these save the person that might have a little high blood pressure. You'd want to be careful of any licorice-containing products. So we're at an hour, but we're very close to the end. So I'm going to throw in about 10 minutes of bonus material. And we're going to just go ahead and knock this out. We're going to go into the last two sections, and this is the male section. So the male section is fairly simple. We're dealing with two problems for males because we only have two problems. We've got prostate and we've got testosterone. So prostate trouble, difficulty urinating or dribbling, night urination is frequent, could be posterior pituitary. Depression, that's testosterone levels. Pain on the inside of the legs or the heels, that's a common chiropractic indicator for hormonal dysfunction. Feeling of incomplete bowel evacuation could be liver biliary digestive, but it may be an overly swollen prostate. Lack of energy is testosterone. Migrating aches and pains is probably more low adrenal function. Somebody that tires too easily, avoids activity, they've basically lost their prowess, their drive. And of course diminished sex drive. So again, in the male patient, we're looking at, is this a low testosterone or is this a hypertrophied prostate? So very simply, Simplex M to address the general approach for any male patient. And we talked a little bit about Tribulus and Orchex. Orchex being the cytosol extract of testicle. So both of those would be excellent at helping to stimulate or fortify testosterone production. Not quite Lance Armstrong levels, but certainly something that should bring some changes in these symptoms. Similarly, we move to the kind of the prostate side. With regards to prostate, we want to influence calcium regulation, and we want to take the stress off the prostate. So we're going to do that by giving them the protomorphogen, and we're going to give them those things to nourish and feed the prostate. Prostex being exactly that. That's part cytosol extract of the testicle, along with some calcium and some other nutrients to support prostate prostate health. The two products here, MediHerb has Prostaco and Standard Process has Palmetoplex. These are fairly similar products, and I don't usually use them concurrently or not together, but I might use them one or the other, or one for a while and then one a little later. This is a saw palmetto product. It also has some pygium and I think some stinging nettle. And these are designed to bring the inflammation or the swelling out of the prostate. And the way that it does that is it prevents the conversion of testosterone to DHT, or the more potent testosterone, dihydroxytestosterone. So fantastic protocol is Palmetoplex and Prostex. And for the acute, or the person that has just been diagnosed with an acute prostate problem, the prostate PMG. And for dosages on these, I use bottle dose. So if the bottle says take 2 per meal, that's what I recommend. Now on the female side of the symptom survey, we're seeing things also, again, pretty common, which is going to be hormonal dysfunction, which is going to show up in the either menstrually or menopausally. So when I'm looking at patients who are still menstrual, my support tends to be Simplex F, OVXP Chase Tree. So these are the patients who are having PMS symptoms, premenstrual tension, easily fatigued, their periods are excessive or prolonged, that kind of thing. painful breasts, menstruate too frequently, all of these are built around an imbalance at either the pituitary or the ovary. So the way that I'm going to be addressing that is addressing the ovary with Ovex, addressing the pituitary with Simplex F or pituitrophin, and also addressing the pituitary with Chase Tree. Probably one of my most successful products is Chase Tree. I use it a lot and get great results. For the more menopausal patient, I'm looking at wild yam complex. This is going to help with the hot flashes and the associated changes that come with menopause. A new product that's just recently come out is Femco. And Femco is a fantastic product not only for menstruating women, but for also menopausal women, in that it really helps support not only the pituitary, but the adrenals and the ovaries, and that it really brings a level of vitality to female hormonal issues. So the primary herbal ingredient in Femco is an herb called Shatavari, which sort of is known in Ayurvedic circles as I think it translates into she with 100 husbands. So you can tell right away that it has an influence on libido or sex drive. And interestingly, it has that effect on both men and women. So I'm not against giving this product to men too, if that's their primary driving complaint is that their low testosterone, their low sex drive. So I may be looking again at things like Tribulus, Femco for the male, as well as Orchex, Simplex M. So we have basically made it through the entire symptom survey. And I know we're a few minutes over the hour. And I'd like to remind everybody of the calendar of events. So on the notes, you can click these hyperlinks to connections to other seminars and webinars that are available through SP West. Of course, the Montana Nutrition Collaboration, which is the second Monday of every month, and a great teleconference from Dr. Stuart White called Mentoring the Mentors, which is every other month on the fourth Thursday from 6 to 7. So right now I'm going to stop the recording of the webinar itself and open things up to questions.